to the next. The next is going to be Dr. Donna Jafari. She's the Chief of Colorectal Surgery at Brookings Methodist Hospital, Director of Clinical Research for the department, and an Associate Program Director for the Colorectal Surgery Training Program. She will be talking about something we are all glad she wants to do and she likes to do, and that is indication for cytoreductive surgery, the Cornell program.
All right, can you guys see my screen?
Yes.
Okay. Thank you. I was going to just do a little quick, these are my disclosures, they're non-relevant, but I like to tell you about them. So I'm going to start really quickly about cytoreduction and HIPEC, and then we'll go into the data. So the way I like to think about anything that we do is what's the goal, especially for cancer. For cytoreduction and HIPEC, essentially the goal is that we macroscopically remove all the disease with the surgery, and then we microscopically treat it with the hyperthermic intraperitoneal chemotherapy. Sorry. And the question is why? So the reason and the main reason why the HIPEC is the controversial portion of this talk is chemotherapy, we don't think penetrates the peritoneum very well because it's not vascularized, especially the smaller lesions. So the disease is disseminated within the abdominal cavity. So the thought of giving that combo of heat and chemotherapy and removing that visible tumor potentially increases your overall survival. They call it the mother of all surgeries. I'm sure Dr. Sampson is going to disagree that I think transplants are a lot more difficult and have a higher complication rate, but that's what the literature will call it. And the way we think about it is, and the reason for that is we essentially go in there. I always tell the patients the cancer is like powdered sugar in a balloon, and someone pops that balloon and it gets all over the room. And my job is to go in there and mop it all out. And sometimes some of the furniture cannot be utilized again, so we have to discard it, and that's where the resection comes from. So it's a combination of essentially stripping and resection of organs, as long as it makes sense. And at Cornell, we try to do a visceral sparing resection as best as possible. This is sort of a representative picture of a man, and you can't see the cul-de-sac, but it's right where my arrow is. Hopefully you guys can see my arrow. That's essentially, this is like an LAR with a perfect peritonectomy. And you can see that in this is a mucinous tumor. And when we think about cytoreduction, we think about completeness. And the most important, and we'll talk about that, and I'll say CCR a lot. What we always want is a CCR 0. We don't want to go in there and do 1, 2s, and 3s because they have had no overall survival advantages. And we're very selective because of that. Then you pour the chemo. This is kind of what it looks like. There's closed systems and open systems. We use a closed system. The data has not shown one is in favor of the other. The patients get chemotherapy. They get it infused about 4 to 5 liters inside of their belly. We shake it for about an hour to an hour and a half, and then drain it, and then do all of our anastomoses. These are sort of the drugs. I wanted to just give everybody an idea. The diseases we'll go through in a little bit, but for colorectal, we mainly now use mitomycin at 42 degrees. Because of Part 7, which we will discuss shortly. For appendiceal, if it's adenocarcinoma, again, we use mitomycin. We can use oxaliplatin for lamin, for the mucinous neoplasms, but the entire country has kind of gone away from that because of Part 7. We will be having a gastric trial soon. It's cisplatin plus docetaxel, and essentially there's a couple of smaller studies, randomized trials that have shown improved overall survival when you do cytoreduction and HIPEC. Ovarian, also controversial. Some centers will do cisplatin and paclitaxel. The difference between colorectal and the ovarian and gastrics is that the platinums can have a huge renal failure issue when you pour it into the belly, so you have to be very cognizant of that. And mesothelioma is a very curable disease, and you can have a median overall survival of essentially like 80% 5-year survival. With epithelioid mesotheliomas, they really act like appendiceal neoplasms, and those are really the fun cases to do because you really change the patient's outcomes. The scientific basis for HIPEC is simple. It has worked in the mouse model. The data in humans is controversial, but again, the thought is that you the heat produces a direct anti-tumor effect. It allows the chemotherapy to get into the cells better. It increases essentially the penetration, reduces the systemic effect because the patients aren't getting systemic chemo unless you're giving oxaliplatin, because then they get a bolus of I5FU at that time. And then direct treatment of free intraperitoneal cells and homogeneous distribution of the chemotherapy. When we go there in there, sometimes it looks like this. And I just wanted to put out that the consensus guidelines, which Dr. Yo and I have both been involved in, have all been published for every single disease. So if you are like, I don't remember the paradigm, just pull that. And we don't have time today to go through every single one. But essentially, the main ones that we do are primary peritoneal pseudomyxoma, which can be by appendiceal cancers, colon, and meso. And appendiceal is two groups, mucinous and adeno. The adenocarcinomas we treat like colon cancer. And then the rest of it, gastric, we're now using HIPAC, but melanoma, neuroendocrine, and breast, which we will do selectively. Really giving chemotherapy is a little bit controversial, but we will still do the cytoreduction. So sort of continuing with the indications is that we really care about the disease burden. Disease burden, and this will be a theme of the talk, is the most important part of our decision making. And the peritoneal carcinomatosis index by Sugar Baker is what we use. Essentially, we divide the abdomen into 9 quadrants, and then we grade the tumors from 1 to 3, depending on size, and then we get a number. The most important thing here is that if the small bowel is involved, people can't live without their small bowel. I also don't like to do total colectomies and endoleostomies. I think that if the patient really truly needs that, their outcomes are not going to be good from an oncological standpoint. Hence the reason why we do visceral sparing, and we try to spare as much bowel as possible, because if the patient is having tons of diarrhea, our medical oncologists are just not going to be able to effectively treat it systemically. We published this, our results. Diagnostic laparoscopy really in the hands of cytoreductive surgeons is the gold standard. We do it on everybody, ideally at baseline and post-chemo. And what we found was it was positive predictive value of us being able to do a complete cytoreduction in 83% of patients. And also it allows for better discussion of patients. So if I know the spleen is coming out, then they get vaccines. I can tell the patients, listen, we're going to do a splenectomy. We're going to do this. This is going to be potentially the quality of life from the bowel resection, the diaphragms. You're going to wake up with chest tubes. So it really helps get or if it's going to be a 3-hour cytoreduction, is different than a 12 to 14-hour cytoreduction. And the patient and the family are ready for that. And it really helps the discussion. It also helps you be able to plan it in your own head. Imaging is the tip of the iceberg. It is not a good modality. We can do PCIs through CT and MRI protocols. However, when the lesions are less than 1 centimeter, it's impossible to pick up, and the PCIs are always going to be lower. And we've done studies on that as well. Selection is key when we think about cytoreduction. You have to have a good performance status. There really should be no other sites of disease, although that's become a little controversial with better targeted therapies for metastatic disease. No progression on chemotherapy, and we want a low to mid PCI, and we want to be able to do a CCR0. I will not perform cytoreduction unless it's for palliation and it's partial to just help someone. If we're not going to get a CCR0, our group is very adamant about that because it has no survival advantage. Contraindication, functional status is the number one. If age is questionable, but if you have an 85-year-old with an ECOG of even 1, we're going to hinder the patient. We're going to actually worsen the patient's quality of life than help them, because that is an important part of cytoreductive surgery that we unfortunately don't have time to talk about today. Disease burden, again, you have to be able to do a CCR0. Anatomical spread, if it's in the pleural and the peritoneum, you shouldn't do it. And then unless it's meso, and then you can discuss it. Poor response to therapy. Obviously, if they're progressing on systemic therapy, they should not be able to go under surgery. And then sites of disease, rectum and hepatobiliary. I would not offer it. Rectum, they have a different pattern of disease, and their prognosis tends to be poor, so surgery is not the way to go. The questions remain today because we treat things a little bit, and we're a lot more aggressive than we were like even 10 years ago, even 5 years ago. What about the patients with systemic disease? We have selectively done liver and peritoneal, and I would have never done that 2-3 years ago, but the patients are still alive and doing well. BRAF mutations with the VR600, like, targeted therapies, patients are alive, they're doing much better. Signet cell, all those poor features used to be definite contraindications, and now get discussed at multidisciplinary discussion. And in the era of new therapies, we let the disease and the biology of the tumor based on how they get treated dictate how they do. We're going to, like I said, focus really on colon because that's where most of the data is. And that's the theme of today's topics. Essentially, 10 to 15% have peritoneal surface with colon cancer. 15% will be at 50% will be at diagnosis, and 50% will be at relapse. And actually, studies postmortem have shown that it's probably higher because you don't pick these things on imaging. Shortens the overall survival by about 30 to 40%. You have potential resistance to systemic chemotherapy. 50% of them tend to be signet cell and mucinous tumor, which have worse outcomes. Median overall survival is about 6 to 9 months. Cytoreduction HIPEC can increase that to 40 months, and take that with a grain of salt. Again, we're selectively operating on these patients, so we pick the best patients with the best biology and best and so we can increase the survival rates. And potential cure of those patients is about 16%. When you look at cytoreduction alone, because HIPEC tends to be a little bit controversial, and everybody except one center in the country still does it. When you look at it alone, this is a small French study, and they actually when they said cytoreduction, these patients had liver and lung as well, and they basically would get rid of all the cancer through 1 or 2 operations. They had 50 patients, 26 patients had other sites that included liver and lung, with complete resection, and these are patients who also got chemotherapy. Median survival was about 32 months, and 5-year overall survival with 30%. Peritoneal surface with cytoreduction alone was 47, which is kind of the number that you'll keep seeing, which is pretty good considering that you have a 10% survival otherwise. When you add HIPEC, again, this is a retrospective of all the studies before the randomized clinical trials come up. And like Elias and all, we just had like 500 patients, and then Chu and Esquivel. These are high centers, and you can see their survival rates are in the 30 to 40% range at 5-year survival. And it's because they're high volume, because you need about 250 cases to get over your learning curve for cytoreduction. And they're selecting patients that are appropriate. So what does the randomized clinical trials show? This is a French study. They basically, the Dutch study, they did cytoreduction HIPEC versus chemotherapy alone. We tried to replicate this in the US, and it was closed because nobody wanted to randomize to chemo alone, so patients would not sign up for this trial. They had about 100 some odd patients, and their 8-year follow-up, essentially what it showed is that patients getting chemo alone, and this study is a little bit old, so less targeted therapy was 12.6 months versus 22 months for patients who got chemo and cytoreduction HIPEC. And what it showed was that patients who got complete cytoreduction had the best response of about 45% of 5-year overall survival. So what this really tells you is disease burden matters. It's like a no-duh thing, but also the quality of surgery matters. And that's in combination with being at a high volume center, and people have done this for a long time. It's a clinical and surgical decision-making paradigm. When you look at all the retrospective reviews before PRODIGE 7, what you find is that, again, disease-free survival is improved with CCR0, experience of the center, and lymph node status, which makes sense. If people have systemic disease and peritoneal, they're less likely to benefit from cytoreduction. This was a trial that we thought was going to really tell us exactly that this was really going to work, and HIPEC was was going to fix all the problems. Essentially, peritoneal carcinomatosis and colon cancer. Everybody had to go underneath essentially a CCR0. They randomized in the operating room. And this is a group of surgeons who are really upset about their trial outcomes. It's very funny when they talk, but essentially there was a bias in the operating room where they thought if the patient benefit from HIPEC, they did not randomize the patient. So there is that bias, and they have actually verbalized that. So with HIPEC, without HIPEC, and then PCI had to be less than 25, and again, CCR 0, and then patients had to be less than 70 years old, and no other metastatic disease, so peritoneal only. So what do they find? What they find is that HIPEC doesn't change overall survival. It's not statistically significant. The limitations of the study, I think, is the number of patients. And then the second thing is when you look at the mid and high PCIs, and multiple retrospective studies have also shown this, is that you actually, even though there's no p-value, positive p-value here, it actually does increase and improve survival. If you look at it, for the mid, it goes from 13 to 21, and for the high 30, basically you increase your survival rate for both of those. And overall, for the entire cohort was about 41%. And then 5-year survival was again in the 30s to 40s. So what this study really shows, and what the takeaway was, and what the US surgeons took from it, and I think the rest of the world, is the biggest thing that people were worried about is that they gave oxaliplatin for 30 minutes. And the thought is the in vitro studies and the mice studies, it was always 90 minutes. Now there's only one center in the US, that's Wake Forest, that does 90 minutes of oxaliplatin. It can be very toxic, so most other centers will not do it. That was one of the limitations, essentially, that oxaliplatin for 30 minutes doesn't improve overall survival. But what it did show is cytoreduction works, and it doesn't increase surgical complications. The HIPEC group had a higher 60-90% complication rate, but it wasn't surgically related. Their surgical complication rates were like 1 to 2%, which is phenomenal. It was basically hematological complications. It really didn't change practice despite what we thought was going to happen. But what it did do is in the US, now we give mitomycin C at 42 degrees. This was at 41 degrees. That's the other thing everybody's like panicking about, for 60 to 90 minutes. That is the only change that Prodige 7 did there. And it didn't even change practice in France either, despite their findings, because again, the survival rates are good and these patients don't have any other options. The reality is that more than 90% of patients will be treated only with combined palliative cytotoxic chemotherapy, and less than 5% will undergo CRS HIPEC. So really, I think the most important thing is always refer the patients to cytoreduction HIPEC centers at the time of diagnosis. Even if you don't think it's going to be helpful, it's very important for us to meet the patients, because a lot of times I'll get patients who bring on chemotherapy for 2 years. They're doing great, but then they're not going to be a candidate because their liver's shot and they're going to just be too high risk because of the amount of chemotherapy they've done, and their complication rates actually do increase. So it's good that the art of cytoreduction is that it's selection and timing. So you got to catch it. The cancer is always one step ahead of you. So as long as you are at the same level, or like you're one step ahead of the cancer, if you do cytoreduction at the right time, it will help patients for adenocarcinoma. So, and we're happy to see them. They tend to be very sad cases, but I think it's important for the patients to know they have options. And then there's potential trials coming down the pipeline, and we will have some for gastric as well, which is important. I'm running out of time, so I'm not going to go over the surgical stuff, but I will say that we are a high volume. We do multidisciplinary care. This is not just the surgeons alone. We have a med-onc partner always during these cases. Every case gets discussed, obviously, at tumor board. We have a very close relationship with Queens and Brooklyn, and we try very hard, because a lot of patients are referrals from far away, is that they get their care at their institutions, and essentially they come for the cytoreduction of HIPEC here, and then we have a very close collaboration with the medical oncologists and the surgeons who refer these patients. We do have a lot of clinical and translational trials that will be coming on, and our team is always happy to discuss any case over the phone, especially if the patients, have a hard time getting in, and we can always do video visits and discuss it with patients. And I will put a plug in for our young colorectal cancer program. A lot of these patients now, we're seeing advanced diseases in young patients. So it's even more important, because if you're 40 years old, that 2-3 years of extra survivorship will make a difference for you being able to, drop your kids off at school. And it's very, very important. So we keep that in mind, and we have a fertility as well as social support for all of these patients. Thank you.
Thank you, Dr. Jafari. This was great. Dr. Shah already has his hand up, but before you do that, you have time to go over what happens if you find carcinomatosis in the urine, because I think it's very important. If you
Yeah,
don't
I
mind
think
going back.
that, sure. So if you're going in there for a symptomatic primary tumor, you have to resect it because essentially you want to get these patients to chemo. You go in there, you put the camera in, and you're like, uh-oh. If the patient's asymptomatic, close up, send it to the medical oncologist, let us know. If you can get me a PCI and some pictures, that would be phenomenal. However, if the patient is symptomatic, which I will never say otherwise, I would do a non-anatomical resection because what you don't want to do is you don't want to create new planes. And I talk to this with the gynecologist all the time because they'll do an oophorectomy, hysterectomy for Krugenberg tumors, but there's no reason to do the hysterectomy. Just take it out, leave everything behind because that uterus kind of protects that rectum, and that makes a huge difference in terms of outcomes for us. So if you're in there and there are huge Krugenbergs and you have a symptomatic primary, take it out, do the lease, dissection and planes, because then you just create new spaces for the cancer to go. And that makes the surgeries difficult. Like if I have to do a ureter resection during the cytoreduction, I question whether I should be there because I'm not sure there'll be a benefit.
All right, Dr. Shah. Thank you, Dr. Jafari. Dr. Shah.
Thank you. So yeah, I think we need to figure out a way to create a program because of your interest, and I think this is great. I have two questions slash comments. So one, when the Protein 7 study came out, I took it as that it clearly in the right patient cytoreductive surgery is helpful. I think that makes a lot of sense, but the randomization to HIPEC or not was negative. And so, outside of like a low grade kind of mucinous type, limited metastatic potential tumor, is there really a role for HIPEC in any patient?
So, it's controversial. And I always tell the patients, because I truly believe that it doesn't increase my morbidity and mortality. My morbidity and mortality comes from the surgery. The hour and a half, honestly, if somebody doesn't want it, is great because then I just get an hour and a half back in my day. The surgery is much smaller. The hypothetical idea of it is important. There have been positive studies, so it's controversial.
Not randomized though, right? This
No,
is the only
no, the
randomized
Dutch study was randomized. So
and that was positive?
it was positive. So there's and then there's like all this retro. So I think the issue is like the liver mets, like trials, right? It's just too heterogeneous of a population. Like the BRAFs, like everybody was included in this. So it's really hard to make. So you're gonna always have limitations of the study because of the heterogeneity of the group. And you there's different patterns of peritoneal disease as well, even for adenocarcinoma. Sometimes they're like big tumors, sometimes there's like this everywhere. So I think it's controversial, and I think we as a group have decided that we won't do it when there's a systemic disease, but we will do it for the mucinous ascites producing, because it does scar that down, and if they recur, the mucin tends to be less. So we will use it in a palliative thing. But I think it's controversial, and there's only one center in the country who won't give it, which tells you that everybody else kind of does it because it doesn't hurt the patient, but it may have some sort of benefit, theoretically.
I think we should figure out what question we want to ask and study it.
What can you elaborate a little more?
Well, no. So if the question is, does HIPEC work? And maybe that's not the most important question, because even in the face of, whatever data we have, we may not move the bar. So maybe that's not the question. Maybe there should be a different question.
Yeah, I think there's we're going to have some interesting studies with the East Hub, the CD40 that Jed wants Rudica and I to work on. Like we're going to put that through. So maybe like a different agent than mitomycin, because we know that the systemic treatments probably, like the reason why we give systemic is basically to weed out the patients who have good biology versus bad biology, and make sure that it's not people who are going to have liver and lung mets like in 3 months. So I think with targeted therapies that are not going to be toxic, I think it may change. Because you need a local therapy for a local disease, and we are using systemic therapy for a local disease, and we're using mitomycin. I think the oxali was better, but the patients definitely do better with mitomycin.
I would just agree with Dorna. You know, this is really hard to study. I mean, we retrospectively looked at some of our data, but these patients are so heterogeneous in terms of volume of disease, location of disease, amount of, you know, organ resection. So it's really hard to do comparative studies. But I do think we need to be, and we have been, Dorna's been, you know, all these patients are presented at our tumor board. I think that's really the key, is a multidisciplinary discussion, because these are super complicated patients.
Yeah, and all of our patients see, as you know, medical oncology because it's important. The other centers, the surgeons will write the chemo order themselves. I actually don't want that, because then I get a second opinion on these very complex cases. I think it's a very it's like rectal cancer, it's a team sport. You can't do it by yourself.
Can I ask a quick question? From
Please.
from the perspective of somebody from Queens who refers to for HIPEC, I just want to kind of follow up on Dr. Fakera's question about what if you open up, see carcinomatosis, and you said that to take pictures. Can you just clarify what pictures to take? Do you take pictures of all the quadrants, even
You don't
negative,
need
positive?
just a couple of representatives of what the tumors look like, and then if you could just get me a PCI score. And remember, the diagnostic labs always I don't go behind the liver, right? That's why we do the diagnostic labs. The most important thing is for me to know is how much small bowel involvement there is, the mesentery as well, and then, you know, what the PCI is. Because if you come back and say, you know, the PCI is 30, I'll be like, okay, let's start chemo. But if you come back and say PCI is 10, I might do a diagnostic lab first so we can figure out if we're going to sandwich it 3 months versus 6 months. So that helps the questions. But just 1 or 2 representative pictures. And I think the most important thing is if you guys can just, and I have a .pci phrase for NYP, it's .mdj PCI, and just type it in there and you can just fill it out.
I would just echo what Dorna said. I think the key is to make sure you understand the amount of portal involvement and the root of the mesentery, because those, you know, we obviously can't take the whole small bowel, so understanding where the base of the mesentery is, and we're not going to do a Whipple for these procedures. So understanding what's going on in the porta and the base of the mesentery and the amount of small bowel involvement those are the key things.
Just a quick thought, like, is a PCI with the advent of portable cell phones everywhere, maybe taking a video of the diagnostic laparoscopy and sending it to you guys?
Sure.
Would that be helpful, or more
Yeah,
more helpful
I mean,
than
sure.
PCI?
I mean, I just don't want to cumbersome you. So the most
Yeah.
important thing is if you know how, you know, because I'm going to diagnostic lab it before site eruption anyway. It's good to have a baseline. Then we won't have to diagnostic lab them when you refer.
So just to clarify before we close, you do a diagnostic lab on 100% of your before going to surgery.
Yeah, because the worst thing that can happen is we open the patient up and say they're not a candidate. And even though you're just doing an X lab, it's going to delay chemo, because we know that really chemotherapy and all is important for these patients. And if you don't, and you know, even if it's just an X lab with nothing else, you're going to render the patient immunosuppressed, and their cancer grows during that postoperative time. So that's why we do a diagnostic lab. And also from planning from the OR, efficient, all of that. And discussions with the patients is also important, because we have to be able to set the expectations for these huge operations.
And the interval between the diagnostic lab and the actual site of eruption?
So we usually, I won't even sometimes stop Avastin if they have a virgin abdomen. But usually we just plan it between the chemos, and you know, we discuss with medical oncology when they're 6 months or 3 months or whatever we've decided is going to be up, and I try to do it right before, about a month or a couple weeks before. We just want to make sure we have updated imaging and updating laparoscopy.
That's great. Well, thank you again, Dr. Jafari, for a very informative talk, and we can stop the recording.